Good evening. Good evening. Welcome to the Pivot Poll. It's Friday night. So, thank you for joining us again for the Pivot Poll for October. I am Heather, and this is Andretta, of course. And we would like to just welcome you to the Pivot Poll tonight. As you have probably figured out, we are talking about, for the month of October, breast cancer awareness and support. If you've been following us, which I hope you have seen us on our walk and pray journey and challenge that we have for the next 31 days. We have committed to walk and pray every day for people who are currently going through breast cancer or who are survivors of breast cancer, as well as their families, their friends, their medical teams, anyone who supports them. So we were talking about when Andretta and I were coming up with what we were going to talk about for October. We decided that we wanted to bring in a medical expert, someone who could talk about, breast cancer and awareness and detection, early detection and prevention, which is key in helping people who are going through or who have gone through breast cancer. So I am happy to introduce Dr. Jennifer Wade-Seaton to everyone. I know her as Jen. Jennifer and I grew up together in Orlando, Florida. And Jennifer is going to come today and talk to you guys, talk to all of us about breast cancer awareness, about early detection, all things breast cancer and breast health related. So, Jennifer, I will turn it over to you so that you can introduce yourself and we can start this conversation.
Well, thank you so much, Heather and Andretta. I really appreciate the both of you giving me this opportunity to bring awareness to a medical condition that is near and dear to my heart. My mother had breast cancer, and she transitioned in 2013 from breast cancer. And with her story, it was important for me to basically bring awareness to the importance of early detection and prevention of breast cancer, because that was one of the concerns with her. We didn't know that she had breast cancer. So, like I said, this is near and dear to my heart, and I am thankful for the opportunity to be on your platform to bring awareness to breast cancer during the month of October. Just a little bit of brief information about myself. I am a board certified OBGYN physician. I attended medical school in Philadelphia at Drexel University. I completed my residency program at Lincoln Hospital, which is associated with the Jefferson Health System in Philadelphia. I basically practiced clinical medicine for over 10 years. I had the wonderful opportunity to take care of many beautiful and wonderful dynamic patients, delivering babies, allowing those women to talk to me about preventative care and if necessary, proceeding with surgical treatment options. And that was a wonderful period of my time, of my life. And in 2017, I decided to pivot, which I love the title of Pivot Poll, pivot and use my clinical expertise in a different manner. I stopped practicing clinical medicine and began a life of just rediscovering who Jennifer is, and just figuring out different areas that brought me happiness, because I found that I no longer received the level of happiness that I experienced early on in a career. And believe it or not, burnout is a very serious issue for healthcare providers, particularly OBGYN physicians. So it took a lot of courage to make that step, because that is pretty much, all I quote knew, in that aspect of my clinical career. So I pivoted and basically began to use my clinical knowledge in a different manner as a utilization management And I'm excited to share that I opened up my coaching business, Balanced Lifestyle MD, where I basically encourage, motivate, and help other women overcome some of those barriers and those obstacles to understand how to live the life that they desire. What is it they need to create in their life to make any transition? Because a lot of times we are just so fearful of the unknown and we are afraid to make those changes. And sometimes it's just a mindset shift and it requires work with others. So I am excited for the opportunity to share my story and encourage other women. Hey, it's never too late to start over, because I believe I was 44 when I stopped clinical practice. And let me tell you, I know a lot of healthcare providers who may not be content in that role of practicing medicine, but they're stuck. They're afraid to move on. So I'm again excited to be here.
Awesome. Well, thank you. So, Jennifer, when it comes to breast cancer awareness, what are some things that we need to be aware of?
Well, the number one issue with breast cancer, it is most of the time a preventable disease. And the prevention can occur in collaboration with your healthcare provider. A lot of times, patients may be afraid to see their healthcare providers or to kind of share what's going on with their bodies. But you have to understand that you need to find a healthcare provider that you feel comfortable with, sharing any concerns or questions that you may have with your body. And believe it or not, most breast cancers are detected by patients. So that's why it's important for you to be in tune with your body and to know notice if there's anything different, that you make sure that you are in contact and you schedule an appointment with your healthcare provider, and they can direct you as to what the next steps are if you notice there's anything abnormal. And as far as the prevention aspect, we'll go into, the different screening mechanisms that are available to help prevent breast cancer.
Okay. All right. Awesome. So do you want to start your presentation?
Absolutely. If that's okay, or if you have other questions you would like to ask, whatever is easy for you all.
We can go ahead and start with your presentation.
Wonderful. Okay, so Breast Cancer Awareness 2021. We all know that October is Breast Cancer Month, and basically society has kind of dedicated this month to like all things breast cancer. But it's important to know that you don't have to wait to see your provider to go in to make sure that you have the appropriate imaging done during October. I like to share that sometimes because there's so much attention to breast cancer in the month of October, it may be difficult to actually get in with your provider or to actually schedule appointments to have the appropriate imaging testing completed. So you don't have to wait until October, but we are here. So it's all things breast cancer. Next slide, please. So I just wanted to show everyone kind of the normal architecture of the breast. The breast is composed of fatty tissue and fibroglandular tissue, along with ducts and things of that nature. And if you see on the slide on the left, you can see the little blue circles. Those are basically, if women are familiar with breast cysts, such as fibrocystic disease, that's kind of sort of what a cyst would look like in your breast. Versus the picture on the right, and the bottom right, you can see the greenish little tinged area. That's what the malignancy would look like. If there's any abnormal cells or any cancerous cells. So yes, absolutely. Thank you. And so the pinkish area where you see the greenish cells or the abnormal cells located to, that's what kind of your normal breast glands look like. And you can see above, that's what a normal gland would look like, versus the greenish speckled areas, that represents what breast cancer would look like. Next slide, please. So I would like to basically start off with a few statistics on breast cancer, and then I'll proceed with risk factors. And I would like to focus a lot on the risk factors because most breast cancers, approximately 1/3 of postmenopausal breast cancers, are linked to modifiable risk factors. So when I say modifiable, those are risk factors that we can change. And then there are also non-modifiable risk factors, such as our genetics, our ethnicity, genes. We can't do anything about those, unfortunately. We're born with what we're born with. We don't choose our parents, and we can't choose our lineage. But there are some modifiable risk factors that I would like to discuss because those have implications in whether or not one could develop breast cancer. So the leading causes of death for women in the United States, the top cause is heart disease, in which there are a lot of modifiable risk factors for heart disease. As we know, February is the dedicated Healthy Heart Month. So, just know that even though heart disease is the number one cause of death for women in the U.S., there are ways that we can change that. Following heart disease are cancers. And the most common cancers in women in the U.S., these statistics are for women in the United States. Breast cancer is the most common cancer that affects women, followed by lung, which we all know there are definitely significant modifiable risk factors when it comes to lung cancer. And colon cancer is the third most common. And again, there are some modifiable risk factors with colon cancer. And then there are some that are not modifiable, such as our genetics and things of that nature. So it's important to know that in average risk women, 1 in 8 women will develop breast cancer. Wow. And believe it or not, some individuals think that most breast cancers are genetic, and that is absolutely not true. Most breast cancers are actually sporadic mutations. So we'll talk about the different risk factors for genetic breast cancers, but it's important to note that most of those breast cancers are not genetic, they're sporadic. And please feel free, I'll stop if you all have any questions you want to ask me about, on that slide, or if you have any other questions that may have come up from your listeners and you see that it relates to here, what the particular slide I'm on, please definitely let me know.
Okay.
So we discussed the most common cancers, but when you look at which cancers actually cause the most deaths for women, there's a reversal. Lung cancer is actually the cancer that causes the most deaths in women, followed by breast cancer. So there's a switch there. And it's important to know that 1 in 39 women will die from breast cancer. And looking at data from 2014 to 2018, and non-Hispanic whites, approximately 100, the incidence of new breast cancers is approximately 131 women per 100,000, versus in non-Hispanic blacks, the incidence is approximately 124 women per 100,000. And in Asian Pacific Islanders, that number's even lower at 105 women per 100,000. Any questions from there before we move on?
No, ma'am.
Awesome. Okay, next slide. So this is important information. When you, I'll get into this a little later, but previously physicians were trained to perform breast self-exams when women went in for their annual exams, just like the preventative check. Now with the American Cancer Society, they've actually kind of changed that recommendation because they've noticed over time that it really does not make a huge difference in the detection of breast cancer. So now, even with instructing women to perform their own breast self-exams, in addition to the clinical breast exam, there's a new terminology of breast awareness, meaning that women should be aware of their breasts and not necessarily performing a breast exam every month, because that was the previous recommendations that you should. I mean, I remember learning this when I was in medical school. You know, you instruct women how to do their breast exams once a month, pick a certain specific date of the month. We are no longer recommending that per American Cancer Society. And so now the language is breast awareness. And what do we mean by breast awareness? You want to look for the signs and symptoms that are present on this slide that may indicate that there's something wrong. Now, it's important to know, just because these symptoms are present, or just because you notice these findings, this doesn't mean, oh my gosh, I have breast cancer.
Right.
But it's important to know, hey, this is something different for my body. You know, if I notice this, let me go in and speak with my healthcare provider. So number one, if you notice a painless lump, or if you notice any breast pain or heaviness, and breast pain is very common, particularly if you're still having your menstrual cycle. You know, before your menstrual cycle occurs, you may experience breast pain. Also, you would like to look for skin changes, such as redness, swelling, or thickening of the skin, and any type of changes in your nipple, particularly if there's any abnormal discharge. Now, this doesn't include like if you are pregnant or if you just had a baby or something like that. But if you notice definitely any bloody discharge, or retraction of your nipples, or any scaliness of the skin. So those are some of the signs and symptoms that you would want to notice. If you notice any changes, you definitely would like to contact your doctor. Any questions with signs and symptoms?
No, sounds good.
All right, next slide. So here we're going to discuss several risk factors. And like I said, I really would like to focus on risk factors because some of these risk factors are modifiable and things that we can make changes. As you see, bullet point number 3, obesity and physical activity. We can all, make changes in that area. Versus our age, there is nothing we can do about our ages. You can't stop that. You know, if you are blessed to keep living, you're going to have a new birthday every year. So the average age of breast cancer is about 60 to 62. And it's important to know that the risk of breast cancer increases until we are probably in our 70th decade. Wow. And once it steadily rises. And once we are in our 70th decade, once we get to like around the 80s, there is a slight decrease in the risk of breast cancer. And studies basically show maybe that decreased risk is because we're not performing as many mammograms on women, in their 80s, or if there are other conditions that women in their 80s may die from. So it's important to know that as you continue to age, there is an increase up into around your 70th decade. And as far as our race and ethnicity, I shared some numbers earlier about the incidence of breast cancer in non-Hispanic whites and non-Hispanic blacks. So those numbers are not too far apart, but there is a difference in the death compared to non-Hispanic whites and non-Hispanic blacks. For Black women, there is a higher mortality. When we say mortality, we mean death. So there's a higher mortality, unfortunately, for Black women. And a lot of that has to do with socioeconomic status as well as access to care. And the type of breast cancer. We'll talk about, I'm not sure if ladies have heard of hormone receptor positive breast cancer being triple negative, whether or not it's estrogen receptor sensitive or progesterone receptor sensitive or HER2 negative receptor sensitive. Those are important when we're discussing treatment recommendations and opportunities for treatment. So, and those women who are triple receptor negative, mean it's not their breast cancer is not sensitive to estrogen or progesterone or her human epidermal growth factor. That's a lot of medical terminology, but that has a lot to do with the treatment. Those malignancies are much harder to treat, unfortunately. And more Black women have those triple negative breast cancers, unfortunately. So going back to the higher mortality in Black women, that again, they may not go see their provider as frequently, or they may not go see their provider at all because of hesitancy and fear associated with the medical community. The Black community has experienced a lot of trauma through the years with, not receiving appropriate care or the inappropriate use of cells when you think of Henrietta Lacks. So things of that nature, where through history, the Black community has a very negative stereotype to the medical community. So there may be hesitancy with seeing healthcare providers. So the obesity and physical inactivity, that's one of the modifiable risk factors. And believe it or not, when we talk about obesity and we talk about hormone exposure, the risk associated there is due to the excess estrogen use. So when someone is overweight, and they have a poor diet or they are physically inactive, they have a lot more adipose in their body. And adipose is a great storage site, if you will, for estrogen. So the more estrogen you may have in your body, it may lead to an increased risk of breast cancer. So that's why it's important to make sure that we are eating a healthy diet, appropriately exercising to decrease that risk of obesity, to remove some of those fat cells, that adipose, which ultimately decreases the amount of estrogen in our body. And also along that nature, believe it or not, a lot of ladies may not want to hear this, excessive alcohol use. So excessive drinking. Some studies have shown that also may indirectly increase the amount of estrogen within your body. Wow. And when we're talking about estrogen, we're also talking about hormones exposure. So for young ladies who may begin their menstrual cycle very early, particularly, let's say age 9, it's known that Black girls begin their menstrual cycle much earlier than white young ladies. So that early onset of menses, late menopause, or if you've never been pregnant, or you've never breastfed a baby, or you've had a shortened pregnancy. All of that relates to excess exposure to hormones. So that means excess estrogen, which basically can be an increased risk of breast cancer. So some of those may be modifiable and some may not, but we definitely can't control the age of our menstrual cycle or menses. And as much as a lot of ladies wish they could, you can't control when you go through menopause naturally, if you will. I guess if we could figure that out, man, would our lives change. So those are some of the effects and the risk factors associated with excess estrogen. Do either of you all have any questions or concerns with the excess estrogen?
I did have a question, and I don't know if there's an answer for this, but why is it that African American girls start their cycle earlier than another group of girls? Is there a particular reason for that?
It could be a genetic component as well as some dietary components. If you think about the experiences of African Americans when they were enslaved, how our diet was different from those of the slave owners. So, our diet through the years may have been passed down through generations, and that can definitely have a genetic component as well. So some of the dietary changes as well as a genetic component, because there's definitely a genetic component with at the time of menopause. Usually if you've noticed that maybe your mom or your grandmother has experienced menopause later on, you may unfortunately or fortunately experience menopause later on in life, because the average age of menopause is 62. But for Black women, that can, last a little bit longer sometimes.
Okay.
Wow.
Interesting.
Good information. Good information.
Awesome. You are welcome. Thank you. So when a lot of women, breast density is like a big thing when you're talking about mammograms, particularly for women who have larger breasts. When they go get their mammogram, their doctors may say, oh my gosh, you have dense breasts, and maybe we saw something abnormal. You may have to go back for another mammogram, or you may have to obtain an ultrasound. So it's important to understand when we're talking about breast density, we're talking about, if you think back to that, remember back to that first picture, how you saw like the yellow adipose, that's the fatty tissue, because our breast is composed of adipose or fatty tissue, but it's also composed of the glandular structures and like the connective tissue. So when we're talking about breast density, we're talking about the comparison of the glandular tissue and the connective tissue relative to the fatty tissue or the adipose tissue. And when we think of breast density, it doesn't mean how firm our breasts are. A lot of ladies think, oh my gosh, my breasts are dense, they're firm. But that's not what it's referring to. It's comparing the glandular and the connective tissue compared to the fatty tissue. And the more dense your breasts are, means the less fatty tissue you have, and the more that glandular, that connective tissue is present. So women who have very dense breasts have a higher risk of developing breast cancer.
Wow.
Along with the density of your breast, if it's really dense, it sometimes may obscure if there's some type of abnormal tumor or something like that. It may sometimes prevent detection on mammogram. So that's where you kind of hear the language of the increased breast density, and sometimes if you're going for your mammogram, maybe they could not receive a very thorough image to make sure there's nothing wrong. So when your breasts are really dense, there's a category of A, B, C, and D. C and D represent very dense breasts. If you are in a category of C and D, unfortunately, you have a 1.5 to 2-fold higher risk of developing breast cancer. So that's why those women sometimes have to go in for additional testing.
That makes sense. I actually fall in the C category. So I'm actually going for my second mammogram and ultrasound in a few weeks. So
I hope that helps explain, kind of sort of, what does it mean when I have dense breasts? Because sometimes clinicians, doctors, we're not great at kind of explaining what that means. And, some doctors may just say, okay, your breasts are dense, you just have to go in for a second look, and not really explaining, what that necessarily means.
yeah.
That's good.
Yeah. Very
Awesome.
good.
Okay, next slide, please. So here, these are these non-modifiable risk factors. We can't change our family. We can't, change our genetics. So if you have a family history of breast cancer, remembering though, most breast cancers are not family history or genetically related. Most of them are due to a sporadic mutation. But if there is a risk, a family history of breast cancer, meaning like a first degree relative, like your mom or your sister. Now we're not talking about dad's sister or mom's great aunt, or like three relatives removed from you. We're talking about first degree relatives. There is a 1.5 higher chance that you could have breast cancer. Now, let's say you have more than one first degree relative, say your mom and your sister. There's a 2 to 4-fold risk of breast cancer.
Wow.
So it is definitely, if there is unfortunately a family history, there is a higher risk of breast cancer. And also, in some families, which we'll talk about, gene mutations, there is certain syndromes, like there may be breast ovarian cancer syndrome, a pancreatic cancer syndrome, or prostate cancer. Usually with those syndromes, there's some type of gene that is present in the family, which increases your risk of breast cancer. So if you have first degree relative with ovarian cancer or possibly pancreatic cancer or prostate cancer, that may put you at increased risk of breast cancer. Now, it doesn't necessarily mean that that's the case. And that's where, it's important for you to have these conversations with your healthcare providers and possibly speak with a genetic counselor to have a thorough history of your family to see, particularly what type of malignancies are present, to see what the next steps may be for you, whether or not you may need to have genetic testing done or potentially have some type of prophylactic surgery, depending if you are found to have one of the common mutations, BRCA1 or BRCA2. And those prophylactic surgeries could involve a mastectomy or an oophorectomy, removal of your ovary.
Wow.
So with the genetic predisposition, a lot of people are familiar with the BRCA1 and the BRCA2 genes. Those are the genes that are most commonly studied and known, but there are other genes that have an increased risk of breast cancer. But those are the two most common because of the risk associated if you are a carrier of those genes. So in the general population, there's a 10% risk of developing breast cancer by the age of 80. If you are a carrier of BRCA1 or BRCA2, that risk increases significantly by the age of 70. And it's also important to know that those women who have BRCA1, BRCA2, they basically have those genes cause approximately 5 to 10% of all female breast cancers that are not like related within your family, but there's also a 15 to 20% risk as well within your family. So BRCA2, there's a higher risk of breast cancer, like 15 to 20%, versus BRCA1, that risk is about 5 to 10%. So definitely if there's a genetic predisposition to BRCA1, BRCA2, you most definitely need to talk with your healthcare provider regarding treatment options for you, because you are not at the average risk of developing breast cancer. And it's important to know, like, believe it or not, the BRCA1, BRCA2 genes, they're not very common. Like, I think about 1 in 400 women may have that gene in the general population, but there are certain ethnicities in which that gene is extremely common, and those individuals are at high risk. So if you are of Ashkenazi Jewish descent, you have a 1 in 40 compared to a 1 in 400
My goodness.
chance of carrying the BRCA1 or BRCA2 gene. So those, if you're of Ashkenazi Jewish descent, you are definitely at increased risk of breast cancer.
Wow. Man. Okay.
Yeah. So that it's just important to know your family history and making sure that you are following up with your healthcare provider if you fall into one of these categories. And obviously, if there's a personal history of breast cancer in one breast, you are at risk of developing breast cancer in your other breast. Well, that's kind of common sense there.
Okay.
All right, next slide, please. Okay, so now here we are talking about the prevention opportunities for breast cancer, which there are some cancers that we can't prevent, like ovarian cancer. There's really no way to prevent ovarian cancer in someone who is not high risk. There's no screening test. A lot of patients may ask for, pelvic ultrasounds, or you may have heard the test, blood test CA-125, but that is not a recommended screening option for ovarian cancer. Those testing are important for someone who's at increased risk, such as someone who has a family history, a first-degree relative of ovarian cancer, or if you are a carrier of the BRCA1 and BRCA2 gene. Cervical cancer. We can screen for cervical cancer. Women should not die from cervical cancer because that is the purpose of pap smears, to prevent cervical cancer. So with breast cancer, again, we have different screening options. So I just want to touch briefly on the different screening options. So most women are familiar with your traditional mammogram, which is basically like a two-dimensional X-ray of the breast. We don't like them. They're uncomfortable. It's just like, man, why do I have to do this?
Yes.
It's not uncomfortable, but we want to do it because we want to take care of ourselves. If there's ever anything abnormal, we want to catch that early so it can impact the treatment and survival. So we all know, ladies, we know mammograms are not fun. And if you haven't had a mammogram yet and you're under the age of 40, just keep on living. Keep on living. So the traditional mammogram, and I'm referring to women who are at low risk. These are not high risk women. So not someone who has that family history or carrier of the BRCA1 gene. The average, you should begin your mammograms at age 40. So there is the American College of Obstetrician Gynecologists. That's like the governing body of OBGYN physicians. Then we all know the American Cancer Society. And there's the NIH and the U.S. Preventative Service Task Force. Like there are all these governing bodies that sometimes have different recommendations as to how frequently you may have your mammograms done. Typically, ACOG, which is the American College of Obstetricians Gynecologists, they recommend if you are of low risk, you can have your mammograms every 1 to 2 years. And it's important to discuss that with your healthcare provider. Whether or not if you are at average risk and you're very comfortable, you are very aware of your breast. Some healthcare providers may recommend 2 years, but you need to discuss that with your healthcare provider. Okay. Versus the American Cancer Society, they also say begin at age 40, but their recommendation is yearly. But again, you would like to discuss that with your healthcare provider. And I go back to that whole breast self-awareness. Again, like I stated, most breast cancers are detected by patients. So just be in tune with your breast. I also already discussed the clinical breast exam, how that was a standard of care for providers to perform those breast exams yearly when ladies come in for your annual exam, whether or not that's with your OBGYN physician or your family physician. That's no longer the standard of care. So I just wanted to mention, the clinical breast exam. But also, there are other types of mammograms. There's the 3D mammogram. And the whole purpose of the 3D mammogram, it basically detects more breast cancers, okay? Like it just has a higher detection rate. But the thing about it is it's more expensive. So some insurance companies may not cover, 3D mammograms. And also some facilities may not have the capability to do 3D mammograms, but it is an option if you're able to have a 3D mammogram, if it's covered by your insurance company and you live in an area that the imaging facility has that, by all means, definitely get the 3D mammogram. I mean, if you think about it, it's just taking an extra view of the breast. So obviously you can detect more with the 3D mammogram. So when we talk about magnetic resonance imaging, MRI of the breast, a lot of ladies think, oh my gosh, I need an MRI of the breast. I can tell you now, insurance companies are not going to pay for MRIs of the breast in everyone. Sometimes they may not approve them in patients where, the guidelines may recommend them. But there are certain categories of women, and this is not for your lady who is of average risk. You don't need an MRI of the breast, okay? It may be a little bit less painful or uncomfortable, but here. So it's recommended in those individuals who are at high risk, and they are typically recommended beginning at the age of 30. So we've already discussed those women who are at high risk of breast cancer. So that means if you carry the BRCA1 or BRCA2 genes, or if you unfortunately had a history of chest radiation to your chest for some other type of malignancy or cancer, you are at high risk for breast cancer. So you would fall into the category of having an MRI done, or those women who have a lifetime risk of developing breast cancer greater than 20%. And when we think about who has a lifetime risk of developing breast cancer of 20%, you basically, those are the individuals who go see a geneticist, a genetic counselor, to, go through their history. And there's a specific type of assessment that you go through, answering certain questions. And once you complete that assessment, it'll give you your lifetime risk of breast cancer, developing breast cancer. So if you fall into that greater than 20% risk, you are an individual who would need an MRI of the breast. If you're less than 20%, you don't qualify for an MRI. Unfortunately, like I said, it's less painful, but you do not qualify. And it's important to know that when you're in that high risk category and you need an MRI of the breast, it doesn't mean you don't get a mammogram. It doesn't eliminate having the mammogram. You need both. You need the MRI plus the mammogram, because believe it or not, MRIs, they may miss some mammograms. Some breast cancers. So those high risk individuals, you need the MRI plus the mammogram. Does that make sense? I hope everyone understands that.
It does.
Yeah, absolutely.
Mm-hmm.
Just know that MRIs are not for everyone.
Yeah.
And breast ultrasounds are not for everyone. Breast ultrasounds are not painful. But unfortunately, they alone are not useful in screening for breast cancer. They are used to assist in screening for breast cancer if something is abnormal on a mammogram. And particularly breast ultrasounds are utilized quite often. Say if there is a 20-year-old who feels a lump on her breast, she's not at increased risk, no first degree relative, meaning her mom doesn't have breast cancer or sister doesn't have breast cancer, no known history of ovarian cancer or pancreatic cancer, say that she feels a lump in her breast.
Mm-hmm.
It's important to determine the characteristic, like certain features are noticed, are present with breast cancer. So typically in younger patients, we don't go subject them to having a mammogram. As we all know, mammograms are uncomfortable.
Mm-hmm.
So for those particular individuals, most likely what they are feeling is not a malignancy most of the time. Because if you're feeling a lump on your breast, that tumor it's been there a while. Okay, because the whole purpose of mammograms, you want to find those abnormal findings on the x-ray when it's early on. That's the whole purpose of early detection. And some of those abnormal findings may look like calcifications, because when they're tumor cells, they display certain abnormal features like calcifications, and that's what the mammograms are looking for. So most of the time, in a young, healthy lady in her 20s, if she feels a lump, it will not be something malignant. It is usually a benign growth, sometimes a fibroadenoma, which is also a tumor or a growth. A tumor just basically refers to an abnormal growth. It's a tumor, but it's not breast cancer. Okay, they are very firm, but they're mobile. Like they're hard, but sometimes you can if you're able to move the growth, the fibroadenoma, and those are benign. They are not at increased. They don't cause you to have an increased risk of breast cancer. Okay. Compare that to like cysts. Some women have fibrocystic breasts where they develop a lot of cysts, and I showed a quick little image of what cysts may look like in the breast. For those women, if you feel cysts, which they're not firm, they're kind of soft and mushy, a breast ultrasound would be appropriate at that time. But in certain occasions, if you notice if there's an abnormal finding on a mammogram, your provider or the radiologist may also request a breast ultrasound. So there is a role for breast ultrasound in determining if there's something abnormal, but such as a cancer, but it's not used alone. It cannot replace mammograms.
Okay.
Any questions in that area with any of the screening options?
No, since you said mammograms are it. Mammograms are it.
Absolutely. Absolutely. All right. Next slide, please. So now, what happens if there's something abnormal on your mammogram? Say you have the mammogram and you have an ultrasound, or, for some reason, if you're in a high-risk category, you have an MRI of the breast. And your healthcare provider says, okay, we see something that's concerning or suspicious. We need to proceed to the next step. So I would just like to share, with everyone what happens when we have those abnormal findings. So if we see something abnormal on those imaging studies, we need to have some type of tissue diagnosis, meaning those abnormal cells require removal, and they need to be examined by a pathologist who looks for certain features or abnormalities that are seen in abnormal breast cells compared to normal breast cells. And that's when you have a biopsy done, okay? You're basically removing those cells, sending them to the pathologist, and they look underneath a microscope to see if there are certain characteristics. So there are several ways that a tissue sample can be obtained. You can either have what we call a needle biopsy, where they are inserting a needle into your breast and removing the abnormal cells that way. Or you can have a surgical biopsy, which requires an incision to remove those abnormal cells, and usually sometimes a larger tissue sample is obtained. So you may ask, well, how do you determine between whether or not I need a needle biopsy versus a surgical biopsy? Because I mean, I know when you hear the term needle, like it doesn't sound fun, and it's still some discomfort. But a needle biopsy is less invasive than a surgical biopsy.
Right.
So, you would like to know, what determines that. So what your healthcare provider, usually if you're seeing your primary care physician or your OBGYN physician, they will refer you to a surgeon to have that biopsy done. Sometimes some OBGYN physicians may be able to do like a needle biopsy in the office, depending on their level of comfort, or in the operating room. But generally, a surgeon performs those biopsies, whether or not it's a needle biopsy or surgical biopsy. And the reason why is because if there's something abnormal and you need to proceed to the next step, a general surgeon is the one that's either going to remove the lump that's in your breast or either remove the breast. So the process is you start with your primary care provider, you go and have your imaging studies done and read by a radiologist. And if there's something abnormal, then you're sent to a specialist, such as a surgeon, to obtain the diagnosis. So as far as whether or not a needle biopsy or surgical biopsy is the mechanism to obtain the tissue diagnosis, that depends on the location of the abnormality, the abnormal cells, the size of the abnormal cells, whether or not it's a palpable mass, meaning you can actually feel the mass. That plays a significant role, as well as the patient preference. Say your general surgeon may say, hey, I may be able to do a needle biopsy in the office, but maybe you as the patient, that makes you really nervous. You don't think you can relax, because we need to make sure that, you're calm, and, you're able to withstand the discomfort of having a surgical procedure like that done in the office, where you're given maybe some local anesthesia, if that is an appropriate option for you. And if you don't fit in that category, you may either have to have it done where you're under light anesthesia, or you may have to have a larger biopsy specimen, where it's a surgical biopsy specimen where you are put under a deeper level of anesthesia. So it all depends on the size, the location, as well as patient preference. So that's why it's important for you to communicate your desires and your wishes with your healthcare providers, and come up with a joint decision with your clinical health.
Gotcha.
So that's what happens when there is a suspicion of breast cancer. So what if, unfortunately, you have a diagnosis of breast cancer? What are the next steps? The next step is to determine how far that cancer has spread. And that's what we call staging. We need to know if it's limited in the glands of the breast or the ducts, because there are different types of breast cancers where they can develop within the glands or the ducts of the breast cancer, of the breast tissue. And there are other different types of breast cancer. But we need to know if it's still within the glands or the ducts, or if it's spread within a certain area of the breast tissue, or if it's spread to our lymph nodes, which are, underneath our arms, or unfortunately, if it's what we call metastasized, meaning that it has spread to distant organs, such as your bones. Breast cancer spreads to the bones, it spreads to your lymphatic system. And the reason why that is all important because it determines the actual treatment outcome.
Okay.
So, and the prognosis, meaning how well you would do after receiving the appropriate treatment for your breast cancer. So, obviously, we want to detect breast cancer earlier on and before it spreads, if possible, out of those ducts, or out of the breast, because that determines the level of treatment versus if it's spread to distant organs or distant body parts. So that's called the staging of breast cancer.
Okay.
Okay. And there are different components to staging where we remove part of the tissue along with if we need to remove the lymph nodes. Most likely when you go through a staging procedure, you have to, the general surgeon has to remove some lymph nodes to make sure that it has not spread to the lymph nodes.
Mm-hmm. That makes sense.
Yeah.
Okay.
That makes a lot of sense. Okay.
Awesome. Okay, next slide. So, as far as the treatment, so I kind of gave you a little brief synopsis. Staging is very detailed, and trust me, it's more information that you all would like to know. But the important is early staging is usually confined to your breast, either within the glands or the ducts or the actual breast tissue, or there are different levels to early staging and different levels to late staging. So the treatment, like I mentioned, is different. So if we catch breast cancer earlier on, we can do breast conserving surgery, meaning if there's a small lump and the cancer is confined to the breast, there may be an option to do what we call a lumpectomy. That's just simply removing the breast cancer tissue and not removing the breast. Okay, and you get to save your breast. Okay, so that's the whole importance of early detection. So we can limit the amount of invasive procedures and the invasive subsequent treatment recommendations. If we can catch it earlier on, then the goal is to prevent, a mastectomy or prevent having to have chemotherapy and things of that nature. So the other option for early stage breast cancer is a mastectomy. So depending on where it's located within your breast and depending on your preference, because some women, they may say, I don't want to just have the lump removed. I want the breast removed to decrease the risk of, developing, breast later on in breast cancer later on in that same breast. So that is where the patient doctor relationship is very important. You need to communicate your desires to your physician. You need to be your own advocate for your health. And if you find yourself with a healthcare provider, unfortunately, that is not listening to you, your desires, your concerns, and they're not explaining to you the different options, go seek a second opinion. That is very important. You are in control of your health. It is a patient-doctor relationship. So make sure you are an advocate for your own health. So the surgical options are, again, the mastectomy as well as a breast conserving surgery such as a lumpectomy. Now, when you have a mastectomy, there's also the options of breast reconstruction, where either you decide, hey, I would like to have implants placed, and that is usually done by a plastic surgeon So your general surgeon who removes the breasts and the abnormal cells will be in consultation with the plastic surgeon who does the breast reconstruction. Okay.
Gotcha.
So early on in breast cancer, depending on the stage, some treatment options also involve radiation, where you target your breast. There's radiation given to that particular area, and the whole purpose of that is to hopefully destroy any remaining tumor cells that may be in the breast, or that may be in your chest wall, or that may be in your lymphatic system underneath your arm, to decrease the recurrence of breast cancer. So a lot of women may have a mastectomy followed by the radiation to decrease the risk of recurrence, as well as decrease the risk of death. And so all of that again depends on the staging, like how advanced is your breast cancer. Okay. So
Mhm.
then we go into chemotherapy and hormonal therapy. And believe it or not, those are options for early stage disease, depending on the type of early stage disease. And there are certain breast cancers where they don't spread like everywhere. Those are not your typical breast cancers. The more common breast cancers, they have a tendency to metastasize, but there are some breast cancers that, believe it or not, they stay local within the breast, and you can actually use chemotherapy or hormonal therapy for those type of breast cancers. And when you're talking about chemotherapy or hormonal therapy, that's what we call systemic therapy, where it's going to the treatment targets all organs in your body, unfortunately. So when you're taking chemotherapy, that's why unfortunately you see unintended side effects such as hair loss, nausea, vomiting, weight loss, decrease in our immune system cells such as our white blood cell counts, which causes us to be immunosuppressed and increases our risk of infection. So those are systemic treatments, which are not, unfortunately, without risk, but they are effective at treatment. And then obviously there are different natural tendencies that one may decide to proceed with treatment of breast cancer, such as dietary changes and things of that nature.
Okay.
So, in individuals who unfortunately have late stage breast cancer, most of their options are going to be with chemotherapy or hormonal therapy. And that's where I mentioned briefly whether or not your breast cancer is significant to estrogen. Those estrogen receptor positive breast cancers, progesterone receptor positive breast cancers, or those human epidermal factor positive breast cancer. There are hormonal medications if your breast cancer is sensitive to estrogen, progesterone. There are different medications that you can take to treat the breast cancer. But if they're not sensitive to estrogen or progesterone, where I discussed previously, triple negative, those breast cancers are a little bit more aggressive and a little bit harder to treat, and you may not have the options to use hormonal therapy or immunotherapy. So those are the different treatment options for breast cancer. And, I just want those individuals that, tuned into this presentation, or maybe you may review it or see it later on, just know early detection is key. And the whole purpose of early detection is to increase your chance of survival, to decrease the risk of having to undergo more invasive treatment options, which are not without side effects. As we all know, you may take a medication to treat, your diabetes, but there may be other side effects from those medications. So medications are not without side effects. There are unintended consequences. So, having to go through radiation or chemotherapy, there are risks associated with that. So if your breast cancer can be detected earlier, you're limiting the risk of invasive surgeries or more exposure to more toxic medications such as chemotherapy, and you're increasing your survival rate. So early detection is key. You want to make sure you're discussing your particular medical history with your healthcare provider, determining what are the best imaging options for you, given your medical history, to make sure that you are taking care of your body. So many times as moms and women, we have a tendency to take care of everyone else but ourselves. We make sure our kids go to their appointments. If we're taking care of our parents, we make sure our parents are going to their appointments, our spouses, whoever it is. We neglect our own bodies.
That's true.
And it may be, I don't know, 5 years before you go receive your pap smear. It may be 5 years before you go get your blood work done to check your cholesterol or your glucose level, or to go get your mammogram. You cannot put yourself on the back burner. And as women, we try and take care of everyone else. In our different roles that we play. We have different roles in our lives, whether or not it's spouse, mom, daughter, community activist, our jobs. Those different roles, they encompass so much of who we are, those different titles, and sometimes we don't know how to function beyond those titles. And the reason why I can say that, believe it or not, because I was that person. Just even as a provider, I don't know if you all know, like, doctors and healthcare providers are like the worst patients ever. Like, we think we know everything. Some providers may think they're untouchable. Like, we're here to save everybody else, save the world, and a lot of times we neglect ourselves. So that story resonates with me because of my mother. My mother, she did amazing job raising my brother and I, but she neglected her health. And a lot of times that leads to unintended consequences. And sometimes we don't know the next steps. We don't know how to pull ourselves out of, oh my gosh, I have focused on everyone else in my life for so long, and I don't know how to focus on me. Like, I have all these different roles in my life. Like, what do I do to focus on me? What do I do to rediscover who I am, what it is that I like? So if you can advance to the next slide, please. With that being said, if you find yourself in that situation where you just don't know what to do, I have all these titles, but what do I do with all these titles? Like, I've defined myself by being, a mom, or just being wife, or being a lawyer, or teacher, or community activist, or a doctor. Like, I don't know who I am beyond these titles and these roles that I have in my life. I have a masterclass that will teach you how to move beyond those roles and those titles. That masterclass is on Saturday, November 6th. If it resonates with you, send me a message on Messenger. I will give you that information. And again, I know this information because I've lived it. I know what it takes to move beyond those titles and how to rediscover who you are. Like, sometimes we may say we lose our voice. It's just that we haven't lost our voice. We just couldn't hear our voice. Like, we show up so powerfully in the world. We don't know. We can't hear our voice because we have all this so many other things are pulling at us. We don't know how to balance all of that. And, we don't know how to take care of ourselves. So if that resonates with you, reach out to me for my masterclass, Beyond the Title, Courageously Embracing All of Who You Are. Not just living for those titles, living for all of who you are. And next slide, please. Thank you so much for joining in. I hope that this talk was very beneficial to you, provided you with some information that you can discuss with your healthcare provider. And do full disclosure, I said I'm not practicing clinical medicine anymore. So anything that you hear on this or you heard on this talk, please discuss that with your healthcare provider who knows your medical history. I am Dr. Jen. I enjoyed taking care of all my patients previously, but I am no longer functioning in that role. So make sure you discuss your medical history with your healthcare provider.
Wow. Thank you so much,
ladies.
Yes.
Thank you,
awesome.
Jennifer. Thank you. You've given us a wealth of information, some things that I didn't even know about. So now I understand why I have to have the diagnostic the diagnostic mammogram and the ultrasound, because I was getting real not happy with my provider last week. I'm like, I just did this. But I understand now.
Yeah, absolutely.
So that was really, really good. And as the things that I found interesting were that, all of us grew up with that self-examination thing. And now to know that it shifted, that is, that's very interesting. So there'll be a whole new group of young ladies who won't do that and experience that. So, what did your takeaways?
Oh my gosh, it was so amazing. Just the wealth of information, knowledge. I really, to be honest, had never even really did a lot of paying attention to the, mammograms and, self-care. I'm probably one of those people that should have been in the master classes you're given, because you're absolutely right. You wear the titles, you do so much, you take care of everybody else. And before I knew it, some years had gone by and I hadn't had a mammogram, which I have one Tuesday. And so what you're saying is absolutely on point. I thoroughly enjoyed the explanation. So now I feel a lot more equipped, even in going into the mammogram and dealing with my own personal health. So I thank you so much. It was absolutely informative. And I'm grateful for it. Absolutely.
Yes.
You are welcome. My pleasure. My pleasure.
Yes, and I want to say to you guys who, I want to reiterate her master class, Saturday, November the 6th. If you guys know, this is right down our alley as far as what we discuss on the pivot poll. We have panelists who've come on here talking about this very thing, getting to know yourself, reviving your dreams, your visions, your hopes, all of those things. And so if this has resonated with you, as she stated, and you're looking to revive those places, become more acquainted with who you are, become more acquainted with everything that you bring to the table, and getting to know yourself again. Sometimes, like I have kids that are going to college, some people are empty nesters at this point, and they just need to rediscover, who they are. And so we invite you to definitely look Dr. Jennifer Wade-Seaton up, and like she said, instant message her so you guys can connect on that level. If you would send us your information, we would love to advertise it here on the Pivot Poll for our viewers and our personal pages as well. And so, yeah, you guys check it out.
I just, before we end the talk, the fact that you said the empty nesters, that is what, those are the women that I need to speak to. Because you spend so much time investing to our babies, and we want to make sure, they have everything, if you will. But in that, we lose sight of who we are. And I can tell you now, my daughter's graduating this year and my son's graduating next year. So I'm in a lot of Facebook groups where a lot of women are discussing, I don't know what to do with myself. I don't know who I am, once their kids go off to school, but you don't have to wait until your kids are gone. For me, I started that journey 3 years ago. I'm like, I am not having a midlife crisis. I love my babies. I love them, but I am not having a midlife crisis when they leave. So it takes time to do the work to rediscover who you are. And for me, my language, instead of midlife crisis, it's a midlife experience. It's just a whole a new experience when your baby leave and are, whether or not they're going to college, the military, whatever, they're leaving your house and they're no longer under your roof or protection, and you can't touch them you want to touch them. It's just a midlife experience. It does not have to be a crisis. You can control that. So again, reach out to me if that resonates with you. If your kids, are in 10th grade and you kind of like, that may be me. Now is the time to start that. Don't wait till they go off to school, because you're going to be fine. We can work through it then, but it may be a little bit more painful and, uncomfortable. Let's try and eliminate that and, start the journey of self-discovery before you get to that point. Just when you said that just like resonated with me, because those are the women that I'm targeting, because I don't want women to experience that.
That's good. And we'll have, I know we had you here for your expertise, but we'll have to bring you back, because I heard some passion coming out of you, right?
Absolutely. I know. I took it to another level. Like you can see the passion even with my master class. I'm very passionate about that. That's not to say I wasn't a passionate OBGYN clinical physician when I was, but I'm in a different ministry right now to women. So that passion definitely comes out.
Yeah, absolutely. We'll have you back. All right, Miss Heather.
Yes. Well, thank you so much, Jennifer, for giving us some wisdom, some tips, and some encouragement. I think journeys, regardless if it's breast cancer or transitions, they're all journeys. And the more that we learn about our journeys, and the more that we reach out to those who have been down those same roads, the better off we will all be. So thank you again.
Thank you, ladies, for this opportunity.
Yes. And thank you, everybody, for joining the Pivot Poll. We will see you October 22nd is our next show, and it will be with a breast cancer survivor. She's going to come on and talk to us about her journey and where she is now. Don't forget to walk. Don't forget to walk. It's still not too late for you to join our challenge. You can find me or Andretta on Facebook or Instagram, and you can join us as we continue to pray and walk for the month of October for Breast Cancer Awareness and Support Month. So you all have a good evening.
Good night. Good night, everyone.
Bye.